of how many people are here this morning. It was I wasn't sure what was gonna happen with the snow and everything, but, you know, now it's gonna be 50 degrees on Wednesday, so we probably won't have much left anyways. So, thank you this morning. What we'll do is call for a roll call. Bill, my colleagues in arm here, will, pull out and do a roll call. Thank you, everybody.
Okay, I'll be right with you. Oh, you're just running away.
Yeah.
I brought nothing with
Go.
Dr. Murphy?
Next to you.
Dr. Papish?
He's excused. He had a sudden departure and had to fill a shift.
Oh, okay. Dr. Larson?
I'm pretty close.
Okay. Dr. Stumiller?
Happy New Year.
Dr. Leno? Dr. Crissard? D. Crissard? Dr. McGinley? Dr. Kim?
Here.
Dr. Chung? Dr. McGurty?
Here.
Dr. Midori? Dr. Supple? Dr. Templeton? Dr. Greenhut? Dr. Raybridge? Dr. May? Dr. Albani? Dr. Rodriguez? Dr. Brown? Dr. Brook? Dr. Cohen?
Here.
Dr. Santos? Dr. Felice?
Here.
Dr. Kakuza? And Dr. Quintero. Okay. And we have 9, so we're good.
Yep, you can keep the pen. I'll keep you writing.
Thanks.
Good morning, everybody. Thank you again for coming. I know, you know, this kind of bespeaks to that we couldn't get a quorum for CMAC this past month. And so, you know, what I'm going to do, in February we have our next CMAC, I'm going to bring forward the suggestion of, could we do 50-50, 50 in person, 50 WebEx? Because I know it's easier for people to, you know, be able to attend from their, you know, offices or hospitals where they are, and it just facilitates more attendance. I think that, you know, this was a New York State, you know, commissioner ruling that came down, and that's why we had to switch to in-person meetings. But who said we can't revisit that issue again? Because I just think, you know, they need to look at it. We didn't have a CMAC meeting because we just, in December, could not bring enough for a quorum. Okay, review of the minutes. Karen sent out the packet with the minutes in there. There was a couple of corrections, otherwise everything looked good. Can I have a motion to approve, or if you want some corrections, additions, deletions, just let me know. Okay, second? Thank you. I appreciate it. Under old business, the supraglottic program, Jeff or Dave, you want to update?
We have about 140 applications, 80 active agencies, more than 1,000 EMTs trained, and about 150 insertions. Generally speaking, it all sounds to be pretty good as far as I understand it to be. It seems like EMTs are able to insert a supraglottic airway in an adult patient in cardiac arrest.
And we had, though, a couple of misses in the beginning, right?
Mm-hmm.
Have we had any more since that one time?
What do you mean misses?
It wasn't successful.
Oh, okay.
Yeah. And my understanding was pulled also and ventilated in some other way, right? So it wasn't like a miss. And
That was nothing done, right,
Nothing done,
yes.
correct, yeah. It's still tough to get data and information, so we're continuing to try and jump those hurdles as they come through.
Okay. So one of the things we'll have to do, though, I'd like to give a short update at CMAC next month. So let's see what we can pull together for the numbers and such. I know New York State should have had, I don't know if they have everything up yet to really have all the information there. Yeah, it doesn't, yeah. So, well, maybe we can remind them of the importance of that.
Yeah, so this is an issue we bring up with the data informatics team with polymetrics every single meeting that we have at the state, and we work with Peter and company from data and informatics to try and get it. And it goes back to being a combination of how was it documented, did the group that, whatever, Jeff helped me with the word here, the ESO or whatever, program that the company is using, agency is using, is it transmitting to the state, is it not? And we even found one locally where the town of Newbury thought they were transmitting all their data to the state, and the state looked at it and said, we haven't gotten anything since August. So they thought they were doing it. The state wasn't getting it. They didn't know that they didn't know that they didn't know. And so
They didn't know.
we're finding these little pockets. Hopefully the new schematron will fix some of these things, and it just continues to be a problem that we're continuing to try and work on.
Yeah, and I think that, this brings forward like how important it is, because, we want to make sure that we're doing a pilot project that's worthwhile. Because remember, we stopped some pilot projects in our history here, but, we were really quite, optimistic that this was gonna be a good project going forward, and that we could really elevate the level that our BLS providers are able to provide with appropriate training and.
Yeah, and I'd like to not stop it if possible.
Yeah, I don't
So-
think they will. They always look at time.
Yeah,
That's one thing.
Right.
They look at the amount of data you have, but 140 agencies is huge. I never thought we were going to get to that number. So I think that they'll have some leeway for us, because I don't think the lack of data information acquisition is our fault.
no,
Right.
I
Yeah.
completely agree.
Yeah.
And additionally, EMTs are loving doing this and they can do it, and I'd kind of like to not take it
Yeah.
away from them.
Just a couple of clarifications. Those 150 applications, that's all within this region,
140 applications around the state,
the state?
yes.
How
Yeah.
many for this region?
That's a good question. You know, Jeff?
Not offhand, no.
Okay.
We can look it up, but it's quite a few. I'll bet
Yeah.
it's 30.
Easily.
I'll bet it's 30 from people that contacted me initially, and ones I was involved with the training and such. I'll bet it's at least 30.
Second question, you mentioned 150 insertions. That purely BLS, or is there also maybe some paramedics as well?
It's purely BLS. There are paramedic insertions, but we don't count those. Yeah. We'll get that data and filter it out.
Are paramedics using the,
They can use a number of different supraglottic airways, King Airway, the iGel, hopefully they're not using the EOA and ETA anymore. But
We're
they can-
hoping.
They can use those for sure, and we'll filter the data to the iGel and to EMTs. Now, it's possible that an EMT with an ALS agency can insert the iGel, have the paramedic verify that it was appropriately placed, and we'll count that because the EMT did it.
And I think I just encourage everyone who, receives a patient with an iGel, just to let us know if there's any issues, any kind of problems. Another way we can capture data, but I think, it was well received, it's been well rolled out, it's a great, kudos to Mr. Violante over there and team, because this was really something that we brought forward, and the state, the agencies have gone crazy about it. The other thing that it helps out is, I think we have to be more cognizant of the medical direction over BLS agencies. It's opening a can of worms, but I think that, it's an important thing we should be paying attention to. So this kind of is a segue to that conversation that, I think is important to have. Yes?
Well, just, this going back to the mist, okay, I think that's gonna be key to figuring out what the mist is, because, is this because anatomical problems, is this because the airway was full of blood, is this because mucus, whatever. What was the problem here, because that's what they're gonna, people are gonna look at. So I think it would be good if we could figure out how to get to the bottom of that. That's gonna be hard, you know, at least having agencies and people who are doing it report that, why they couldn't accomplish it. Because otherwise it's just missed, and that doesn't mean much.
Right, I know one of them was a training issue, and that person was remediated and has done fine since. I don't know the other one, though.
And I think you're right, Eric. I mean, no one should be, just any QA, right? No one should be afraid to bring things
Right,
forward, because that's how we learn. We have opportunities for improvement, and this is how we guide. It's not punitive, it's really, you know, something we need to learn from and to figure out if there's issues that we need to work on. So I encourage everyone to, you know, discuss this with your teams. We make sure there's good medical control and medical direction over agencies, and I don't know, I think it's helping, but, you know, we'll continue to move along with that.
David, how do you define a failure on that? I mean, is it just failure of the, they pull it, so they decide it was a failure, or the vital signs don't turn around?
Right, so one of the key indicators is end-tidal CO2, and so if they have crappy end-tidal CO2 readings,
Put
or
an
they're
arrest,
not
you might,
good,
right?
or they're not good, like you're not hearing the lung sounds, and there's, you know,
It's kind of person to person.
air
how they
around
define
it, yeah.
And they just moved to another, they just probably did a BLS airway, you know, they'll just move to another.
Into OPA and stuff.
Yeah, another alternative. But again, I think that we have to look at all of these, Joey. I think it's really important. And so, you know, we'll move in that direction.
It would be interesting to break it down for possible equipment failure too. If all of the failures occurred with iGel and all of the successes are with King, then, you know.
Oof. Oof.
Or vice versa, it would be interesting to have
Yeah.
other departments be able to choose what they want to use.
This study is only iGels.
Yeah,
They're
Oh,
only
okay.
using iGel on
yeah,
it.
because it's the newest adjunct, I can
Yeah.
speak. I'll get through this meeting well, that we've introduced to the BLS arena. So it's a pilot project out of CMAC, so it took us 2 years to get that going. Okay, service upgrades. I have 2 this morning. The Macy's at the Palisades Center is now a pad site, and Olive FAS, First Aid Squad, right? Okay, good job, Murphy. Got CPAP, which are adjuncts we move forward to the state with approval. I have a few unfortunate little citations to read into the minutes from the DOH. First is for Joseph George, used to be in our region, but not since last year. This is a revoked certificate by the DOH for violations of Part 800, and it was effective October 20th. Joseph George. Next is Stephen Rivera, also a person credentialed in our region, lost their credentials back in 2022, and this is a result of an investigation by the DOH and suspended for a year, and placed on probation and assessed a civil penalty of $1,000 for a Part 800 violation. Christopher Langevin, out of Milford, Connecticut, also an investigation conducted by the DOH, suspended for 1 year effective November 23, and is assessed a civil penalty of $1,000 for a Article 800 violation. Catherine Sipple, out of Yorktown Heights, again, same, after an investigation, suspended for 1 year, assessed a civil penalty of $1,000 for violations in Part 800. She has quite a few subsets. I'm not going to read them all. And lastly, Tygus Besh, I'll say is the best way I could say that, out of the Albany area, under an investigation. A certificate was revoked October of 2023 for violations of Part 800. Okay, evaluation subcommittee report. I don't think there is anything, Dr. Felice, right?
There was one case at the end of November that Jeff brought us that Dr. Papish and I reviewed. I mean, I can spare you the details, but it seems like we had it actually go up to the state level
Yes, it did.
for review. I mean, I think we probably can leave it there. Also, the medical director of that agency is not here.
Okay. So more to come on that one.
I think so.
Yeah, we'll follow up on that one, and
Interesting
we'll-
case, like clinically, and outcome was actually very good for the patient ultimately, and
Okay.
sort of go back to that.
And everybody understands that the subcommittee, which has been taken over by Dr. Felice now, is an evaluation subcommittee where you can submit any cases that you want to be investigated. We ask that the investigations start at the level of the agency with the medical directors, and if it doesn't get resolved or there's issues outside of the control or purview, then it gets bumped up to us here at the region. Helicopter committee report, Dr. Larson and Stu Miller.
Well, okay. Actually, what I'll defer to the agency.
So we presented some information on the 2023 scene activity statistics. So just for the group throughout the Hudson Valley, between LifeNet and Hackensack, we transported 325 patients by helicopter or airplane. Well, helicopter for our scene missions. And that was from a total of 1,487 requests for service. A lot of those come from auto standbys where, based on initial 911 report, the dispatcher, through protocol, will identify sort of a, high priority symptom or complaint, and they'll place us on standby so that way we're ready to go when the initial first responder identifies the presence or the absence of that indication, which is about a 21% conversion rate. Which is right at a sort of healthy ratio for what we expect with an auto standby policy there. The more rural you get, the more frequent you see the transports. Most of them were out of Sullivan County with 132, followed by Ulster with 73 of those. We also broke down into the in-air standby criteria versus just a ground standby. For our programs, we say if the point of injury or the patient is more than 15 nautical miles away from the closest aircraft, even if it's just a standby request, we'll put that aircraft in the air and start in that direction to accommodate that longer distance, so that way we don't introduce any unnecessary delays in accessing the patient. And from that, out of those missions last year, 33 required blood products be administered to those patients en route to the hospitals.
So something was brought up to me, just an aside. They were seeing, I get information from transfers from different agencies in different places, and the comment was made, they feel like a lot more is being put on you guys for transfers because they can't get ground units.
The short
A
answer
trend?
is yes.
Yeah. Yeah.
Less so in the Hudson Valley region. We definitely feel a strain more so in the North Country. COVID had an interesting impact in that it both added stress to our system in that the ambulances were tied up. We saw a decrease in our frontline healthcare workers on the ambulances themselves, fewer units available, more patients. But it also sort of forced a lot of the first responders in the hospitals to better understand the capabilities. So we saw an influx in some lower acuity patients. That led to some conversations with the hospitals and the first responders about where the line is. But it also introduced new patient populations. Historically, helicopters were trauma, and that was what people were comfortable with. I think through the pandemic and just a lack of other resources, they realized there's a lot more indications than just trauma. I think
Time sensitive,
Right.
your
Right,
STEMIs, your,
especially neuro.
yeah. If
Up
it's
to
a real,
the Catskills, that's something that's been accessed, and we've seen a lot of really good outcomes as a result. But again, it sort of forced us to learn that lesson the hard way with the first responders in the hospitals when the ambulances just weren't available.
all right, thank you.
Absolutely.
And just a couple points. Just, if you notice how many of these auto launches go on, I mean, that's a very expensive process every time you fire up a helicopter. Okay, so we appreciate that because it does increase, or decrease the response time greatly when it does happen. But so often, they get turned around. Which is okay, but it's something that we have to monitor in terms of, because, our first response on the ground is when we see something bad as a medic in the field is, call for backup and stuff like that. So this is a critical resource and it's extremely expensive. That's one thing. The other thing is just a note that there were 32 times where blood products were used, right, in the last time. So, again, here's something where we're using, you know, something that I think has really been pretty much proven in the trauma world, that blood makes a difference, okay? And it would be nice somehow in the future is if we can, you know, and it'd probably be, you know, retrospective studies, but to show the difference in outcome between trauma patients who receive blood in the field as a parent. And those studies have been done in some places, but it would be, you know, a nice thing in terms of the helicopter world, in terms of improving its work. So, just those 2 points.
And I think, you know, we have to keep in the back of our mind cost containment too, I think.
Absolutely.
You know, because sometimes this filters down onto the patient, and then, you know, you guys are in a position of, you know, trying to negotiate and help out, and, you know, you guys provide a lot of care that is not reimbursed, and I know you guys try a valiant effort, but we need to, you know, we need to look at all these things, and really make sure we're using it wisely.
Unfortunately, we're in a really good position with the counties where there's a lot of dialogue back and forth where we can take a look, you know, quarter to quarter, month to month, you know, is this translating into, you know, actual need for service, or can we drop this down? So that's something we review pretty often, and the counties are very receptive and aware of that. Unfortunately, cost containment wise, you know, we understand with the healthy auto standby policy, 80% of the time it's going to be a cancellation. And unfortunately, most of the time it doesn't translate into an aircraft getting into the air. But we monitor that because, like I said, you know, it's not an inexpensive process. We've been pretty good about, you know, insulating the patients from taking on the burden of that cost, but something we're still mindful of.
Yes.
Quick question, clarification. Of those 32 administration blood products, were any of them seen falls?
All of them were seeing falls. So that doesn't include the interfacility transport.
So blood would be administered like this in the trial?
And-
What do you typically take out? What do you get in for?
I'll let Dr. Sumo take it.
We have O positive blood mostly. O negative is in such shortage. And the never frozen plasma is A positive, typically. And more recently, we've had low titer O positive whole blood at more and more of our bases provided by the American Red Cross.
I think if you look at the statistics, when I was in Afghanistan in 2009, our emergency helicopter that was run by the UK, British, routinely went out on combat missions and took the anesthesiologist with them, and always 4 units of blood positive cells and I'm positive that we would see some extraordinary statistics of lives
Right.
saved from it, no question about it.
Yeah, I think that's where, you know, some of the, certainly the data out of the Iraq and Afghanistan stuff is what pushed some of this into, you know, civilian world.
The other thing is a gallant effort by you guys to get the blood product.
Oh, yeah.
That was
That,
crazy. That was crazy. They have to get permission with every single institution, you know, so they've gone out above and beyond the call of duty, no pun intended, to get that in place, and it was amazing, actually.
And in New York, we really have the Flanagan family to thank. In very, very short version of the story, nurse anesthetist out of the greater Binghamton area was helping family on the farm up in Shenango County, got caught in corn picker, both legs caught up in the auger. Fortunately, the Carhartt coveralls snapped the right bolt so that it stopped spinning, but he was still stuck. The local LifeNet New York aircraft was switching from their spare aircraft to the primary, so we sent the next closest, which was our Pennsylvania-based aircraft. New York at the time, we could not carry blood products under the regulations. Pennsylvania, we'd been carrying it since the base opened. And just because that happened to be the next closest asset, we sent the Pennsylvania aircraft, who had blood on board and was able to save his life. And just, he and his wife were both nurse anesthetists, literally from the first day at SUNY Upstate with 2 freshly amputated legs. He was doing interviews with the media and advocating to overturn that regulation. So, and because it was the right story, with the right people, with the right information, we
At the
were
right
able to
time.
get that conversation going.
Yeah. Thank you. All right, sorry? Oh, sorry, Rich.
Just a comment about the helicopter. A couple of years ago, this agency, meeting with Dr. Stu Miller, Bel Air Ski Patrol was not allowed to call for helicopters. And we met with Dr. Stu Miller, we put that in place, and one of the requirements was that we did an annual training, and that training was completed on the 17th and the 31st of December.
There'll be a lot of skiing now with the snow. Okay,
For about 2 days.
then it's over.
We had 6,400.
But then the accident rate will go way up, as it all turns to ice.
6,400 on Bel Air?
Yes,
That little
yeah.
place, wow.
Yeah.
Good lord.
Right?
And we filled every bed in our patrol room.
Yeah, I was just gonna say, now more trauma and injuries. Quality improvement report, Jeff?
Okay, I'm going to tag on to what David was speaking about with data. One of the problems that I found probably a month after we started this was the data from the ESO platform was not transferring properly to the image trend bridge. So I would read an ESO chart and I would see placement of a supraglottic airway. I pull up the corresponding chart, it's not there.
Yeah.
We have brought this up every time we talk to Peter and his group, and nothing.
So maybe we can circle back with him. He was really, came here right in the very beginning when we started this whole process. He came to, start with us to even look at, because I remember him sending me an email. I didn't know who he was, sorry. But, yeah,
So
we.
the chairman of the council, Mike McAvoy, myself, have both talked with him and with Ryan. Ryan Greenberg's the director of the Department of Health, and he apparently does shifts out on Long Island occasionally and was doing a night shift and couldn't complete a PCR, so he called Peter at 2 o'clock in the morning. And he's like, knock this crap off, I'm done with this, shut everything off. This is not working. So hopefully we'll see an improvement with the latest schematron mask, and all of the vendors have to and can report the NEMSIS data. Where things get tripped up is in some of the state data, and it's like a quick, needed done yesterday northerner talking to a relaxed, laid-back southerner, in some of this stuff and way it goes and way it doesn't go, and some of it just does not translate across very well, even though it seems to be the same language, and so. And that's no slight on anybody whatsoever. I'll put it on us that way. But we're still working on it, and we'll continue to do that. And maybe that's something we really need to do more so with Ryan to try and get this figured out.
Sounds good.
So there are times that we will find charts because I'm specifically looking for them
For
on
that
the bridge,
specific one, yeah.
but they're not coming up in the state daily report. The state daily report probably covers 90% of the insertions that we get reported through Drupal or through an email, or we do have agencies that simply email us the redacted charts themselves. So we're picking up the data. I think this morning we probably have close to 160, but I've yet to verify a handful of them. So the data is coming, but I'm sure that we're still missing some.
Yeah, no question.
And as David said, the next version of NEMSIS, the New York State schematron is dropping from 1,000 rules to just over 300. Some of us lobbied for no state schematron and just accept the NEMSIS data. That did not go over well, but we did push for it. We'll see what happens with 3.5.
All right, well, keep us posted. An ongoing issue. Protocol Committee, Mr. Beninati.
Thank you, Dr. Murphy.
Is it your last one, or?
It is.
It is. How long you been doing Protocol Committee, Mr. Beninati?
Well, I probably since 1998.
Jesus.
And that's full time. Before that, I was still a volunteer, but I've been full time since 1998. So it's been a few years.
So I just want to say I was lucky enough to attend a really nice send-off for Mike. If some of you don't know, he retired from LaGrangeville, and I went to the agency and headquarters and the fire department, and it was just really lovely. I think, you know, you have to understand, Michael, what you've done for this region for so long, and I hope that, you know, we can loop you into other things, but I understand you wanting to pass along the torch of the protocol committee. So we're gonna send out a memo to people on the protocol committee to see if somebody wants to step up to be the chair of that committee moving forward. And we had a few names that we thought about, but yeah, all that being said, since I totally interrupted you, you can continue.
No, that's fine, thank you. And it's just a different chapter, that's all it is. Yeah. So I do have a few items. At the last protocol committee meeting, we had a guest speaker. Her name was Mandy Nann, N-A-N-N. She was from the New York State Office of Addiction and Support Services. And she talked to us about the opioid overdose prevention program and leave behind kits for EMS. And so there's a really good opportunity for EMS to get involved in that and do some leave behind kits. We did receive some information from her. I will ask Karen to send that out. I'll send that to Karen after the meeting. Maybe she can get that out to the REMAC, and certainly please make sure that your EMS agencies get it as well. Also, there was another law that was recently enacted, Matthews Law, which allows healthcare professionals, which are covered, to hand out test strips. The legislation does not specifically mention EMS, but certainly it does talk about healthcare as a whole. And you know, we know that there may be some significant value in having test strips out there. So we'll make sure that we get that information out there, and there's lots of resources, free kits, and all that stuff, including some surveillance dashboards. So other items, we've already covered supraglottic, the RSI program. We didn't have a report. Just to hand it off, Rich Wiley is the chair of that, and he hopes to have updates out on the RSI program in the near future. The medication shortages rates continue to still be a problem. That had been tabled for the December CMAC meeting. As Dr. Murphy indicated, that did not happen. And so the next meeting is February. And so hopefully then we'll get some additional information on that. The Bureau's policy statement on that topic needs to be significantly updated. The minimum equipment and medication list was distributed to agencies. Last I knew it had not been up. We were waiting for Jeff to get back. Jeff, has that been uploaded to the website yet?
It's been up there for some time.
Good, thank you. So that is now up there. So agencies now can look at that new minimum equipment and medication list. What we really did is we parted it down to have enough equipment to essentially treat one patient. That's the responsibility. There was an excessive amount of stuff on there that just had been added year after year, and so now it's essentially to be able to treat one patient.
And it also was leaning towards expirations and loss of revenue and you know, spending money on things that just sat there and got expired.
Let's go
Real
ahead.
quick, we tied it to the protocol, so it's the minimum amount required to treat one patient based on New York State collaborative protocols.
So Rockland mentioned, you know, that they're working actually on a sustainability committee, and they're waiting for their first current meeting. A few other odds and ends that I just want to announce that tomorrow, Paige, Wolfberg, and Wolf are holding a town hall meeting at 2 p.m. Online from 2 to 3:30 on the Elijah McLean guilty verdict and the legal review of that case. So for all of you who may or may not know about that, that's the ketamine case from Colorado where the practitioners have been convicted. And so I think that it would be a good opportunity for everybody to sign up. You can go to PWWEMS Law and sign up. It's a free webinar. And they do hold, you know, these programs from time to time. It's PWWEMSlaw.com.
So that case, the young gentleman was in police custody, still acting pretty violently despite their efforts, and so the police asked the medics to intervene They gave him a dose of ketamine, which, you know, we need to look at the dosage, I think. And the gentleman was put onto a stretcher, and their testimony is that the police wouldn't let them render care beyond that. They gave the medicine, and they never really got to be near the patient again. So we'll see what the process, and he died. We'll see what the process shows there, but you know, it's a really sweeping, you know, investigation, because you know they tried and convicted them.
So certainly, you know, significant implications from an EMS practitioner's perspective, right? This is unfortunately, you know, the way that society may be turning, and there certainly are a lot of practitioners that probably can learn a lot of really good lessons from this.
Well, I wonder too, I don't know, like, because some of the materials have not been released, they might talk about it more on the seminar, the webcast, is, you know, when it came down, when the order came down and they, you know, administered the ketamine, the police they were first up to bat to be held responsible for his death. Did they name the EMS guys, I wonder? You know how in every legal issue, there can always be that you name a third party. I just wonder, I don't know how it came down, I can't speak to that. Hopefully we can get more information. It was limited what you could read, but, you know, just, I thought about that.
I think they did.
Yeah, I don't know.
From my reading.
I don't know, I can't confirm it, but that's my thought process of how the sequence of events went, but it means a big impact for everybody in this room. Sorry, Mike,
No, this is great. This is
I
why we need a
interrupted
great
you again.
discussion.
Yeah, I know, because it's an
I mean,
amazing case. I mean, I sent it to you
absolutely.
guys that morning when the
Yeah.
jury verdict came down. I'm like, what?
And when you sign up, you get a unique link. So I
Yes.
can't share the one I have with anyone.
Right.
You have to sign up and get your own unique link. And the other aspect of this instance is that the tone of it is it wasn't a medical treatment of an agitated patient. It was a police request to help control an agitated patient for police work. And that's where I believe the issue became more of a legal case as opposed to a medical case, and that's maybe why.
Well, that's
maybe,
what it
maybe
was.
that's what we're gonna hear.
Well, it was prosecuted under civil law, not under medical malpractice, if I'm not mistaken, right? So
Yeah.
that's where the difference, I think,
Yes.
comes in. And, you know, that's not what we're protected for. We're not protected for civil litigation.
Yeah, it wasn't a out-of-control human being who needs to be treated for their agitation and brought to medical care. It was an agitated human being who was requested to be, help the police to restrain.
And,
I think that's the way I-
and it looked like they would not allow them to really monitor the patient after the administration of the medication, was what I was reading. All right, more to come. Let us know, Mike.
The next go ahead.
I was just gonna bring this up, and maybe you'll mention this, but Dr. Papish asked me to bring up the push dose pressor, epinephrine with RSI, and I don't know, when you mentioned the RSI protocol, if that's what you're referring to.
That was brought to that committee, so the subcommittee, so we should ensure that that gets, again, probably won't be at future meeting, I may not be, but certainly should make sure, and I will bring it up. We have a protocol committee meeting later this month that I'm gonna chair, and we'll make sure that that's in there. But I know I pushed that information forward.
Yeah, definitely some of our northern country colleagues, Jeremy Cushman, definitely, they're, no pun intended, pushing for those kind of part to be added to our protocols, for sure. That was something that came from those guys up in that region.
And I don't remember, that may already be in the changes that are pending.
I think they are, but I can't say for
recall.
sure, to be honest with you, because I thought I was gonna see all the stuff they were gonna bring forward, but I couldn't go to the December meeting either, so we'll see it next month.
So a lot of, obviously EMS continues to be in crisis. A lot of really good work is being done at all levels. Did everybody get, and I didn't remember to send it to this group, the link for Honorable But Broken is out. I will send that to Karen as well. That's worth seeing. It's a 45-minute video on the EMS system, and it was predominantly done in this area. Dr. Larson certainly had a big part of it, but the link is now out for public access, and you should all please take an opportunity to do that. There's a lot of really good movement to reform the EMS system in the state. And the New York State Rural Ambulance Services Task Force held some town hall meetings. Actually, we're currently scheduling 2 additional meetings, again, for Karen, but I will send that to her once I get those new dates and times, and those are meetings that you can just sign in. It's about 2 hours. But certainly you have, it provides you with a really good opportunity to see what initiatives are being looked at the state level, as well as for us to get some feedback from you. The paper is actually currently being written, so we have a little bit more time. And in fact, the paper is being written by one of our previous executive directors, Ray Barashansky. Ray is contracted with the state to write the paper. And so we've been working with Ray to wrap up that work.
It'll be edited, all this curse words will be edited out.
Yes, I think that we'll probably take care of that.
Okay.
There's been lots of edits. Yeah.
Well, that's a blast from the past, Ray Barashansky.
Yeah.
Wow.
So the next thing is that there are monthly EMS leadership meetings that the state holds. One of the things that they're going to incorporate as well is they're going to try to do like a mini training class as part of each of those for leadership. We certainly have identified that one of the bigger challenges in EMS in New York State is lack of training for leadership personnel. And so I believe at the January or February meeting, whichever the next one is, Mandy Mann is actually going to do the same presentation she did to us for the entire state. And so that'll be a good opportunity for EMS leaders to start to know what's going on. We've been really hounding the state on the Bureau on the need for increased communications. And then, finally, again, Dr. Murphy mentioned that I have retired from LaGrange. I will chair the next protocol committee meeting just because there wasn't time to do that, and now I feel it's appropriate to hand the reins over to somebody else. I wanted to take an opportunity to introduce the Deputy Chief, Anthony Champion. He's getting stuck with my duties in the meantime at LaGrange. He'll be assisted by Lieutenant Scott Merritt. Certainly need to thank Dr. Murphy. She's been our medical director for many, many years, and there's nobody better to have for a medical director than Dr. Murphy. We've actually been doing this stuff a long time together, and we've made a lot of really great progress. And I mean, she is the advocate, right? She's our for the entire region. So thank you so much, and we can't do it without you. Thank you.
Anthony's still smiling.
It hasn't sunk yet.
Hasn't sunk in yet.
John's offered to come over and help, so that's what I'm
I spiked his coffee when he walked in.
Very good, very good.
And thanks to REMAC for all the support of the years. Thank you. That's all I have.
Well, thank you.
Thank you.
We're gonna take them out on, I guess it's next Friday, right?
Yes.
For a little send-off party. Okay, new business. I don't have anything.
Did you see that?
There wasn't one. Oh, you guys had your meetings though, sorry.
No, that's okay.
That was very rude of me.
No, you don't have to do it. That's fine by me.
No, SEMSCO did occur because they had plenty of people to show up and the committees did, sorry. I'm just, because it's CMAC report, I just totally went right over it.
No, that's okay. I sent out this to everybody, so you'll have it. I just want to give some really quick highlights. There's a workforce salary survey that's out, that's available online. I'll piggyback Mike's things to Karen so she can include this and stuff going out. Sorry, guys. The budget recommendations from the state EMS committee went out, and they looked at increasing training by 5%. This was important for the region. Program agencies by 28% and regional councils by 11%. There hasn't been updates of that much in 20 years, 30 years?
More than that. It's 1996, I think, was the last time they had an increase.
So that's really, really good. And we have the year of the governor, which is really very, very good. And she's realized that EMS hasn't been on anybody's radar at that level for a long time, and so I think we are right now. Some education, things that are changing a little bit is the Department of Health is really trying to take things out of policy and put them into regulation, because they believe that some policies are just not enforceable, so they're trying to put and move things in towards a regulatory capacity. And so you may see some more things moving towards regulation and out of policy at the end of the day moving forward. The other thing they're looking to do is to sunset the EMTCC program, that's a New York State program, and have folks either move down to AEMT or up to paramedic. They can easily do a paramedic bridge program, and it won't cost them anything. It's all online, and they can use local resources to do the practical components of it. So it's no cost to providers, and it's an easy thing to do. When they first started the Northwell Bridge program, they had about 400 plus people, and the classes now are down to like maybe 6 or 8 people. And so they believe that, and this, they're trying to be transparent, they're not trying to force this on anybody, but they are looking to sunset the CC program. I talked about legislation and regs. The New York State Association of Counties is starting to take a lead on legislation on their own in terms of EMS. So they're reaching out to EMS folks, agencies, REMACs, REMSCOs, physicians, to talk more about what does EMS look like as we move forward, to try and figure out, can we get ambulances to people who need them? And so that's happening as well.
And that's positive.
Very
They're
positive,
really,
yes.
they're doing a great job. We interact with them, we speak to them. They're really doing a really good job. So that's positive.
Mm-hmm. The safety subcommittee talked about making sure that agencies adopt all the policies as required by Part 821P, as in Paul. So your agencies that you're signing off on, please make sure that they have all the policies in place necessary per those regulations, because the state really is, and the state's here, we can talk about this if necessary, right? They are really looking to agencies to make sure they have everything they need to be doing, all the policies, all the things in place. They're really starting to do that a lot more and more, yes?
Yes.
Okay. So there's a plan for 2024 from the safety subcommittee is to really work on the reduction of lights and sirens. Going to calls, but then leaving it up to the crews where they need to use lights and sirens going to the hospital based on patient acuity. And what they're finding from the research is that there is no negative impact on patient outcomes so far. And this is something that's a NEMSCOA measure, National EMS Quality Alliance measure, that they're looking at. So we may see more of that coming this year. The quality improvement manual is online. We're trying to do more on the state website in terms of looking at the quality measures for agencies to do. We have started, we did this in Dutchess County. We got asked to come up to Ulster County to do a quality improvement program. We're going to work on that at the regional office level to provide this out to providers around our region as well for a quality improvement process based on this new manual. And we'll talk about iGel. Our own Dr. Jeff Raybridge is now chair of the SUMSCO. Oh, sorry, CMAC, excuse me. So that's fantastic, although he had nothing to do this last time around, unfortunately.
So Lou stepped down?
Lou stepped down.
Wow.
Yes. Two other things that are really sort of important for the group, this group especially, is credentialing and performance standards. These are two tags at the state that is new business that is coming down and looking at the credentialing process for providers and the credentialing capabilities of local REMACs and REMSCOs. And so one of the things that we did at the protocol, correct me if I'm wrong with this, is wait for this credentialing process to finish out before we decide what we were going to do here. And what that might mean. The other piece of this is looking at performance standards for agencies, and that agencies would have to meet some kind of standards to be able to remain an agency in New York State. It couldn't just be, oh, I'm an agency now, thank you for coming, have a nice day, even though I'm not doing anything. And so some agencies may fall into guidelines, and that tide is also looking at those standards, and we'll release those when they come out too. So these may have some effects on how we do what we do, where we do it, and who can do it. And if there's anything you'd like me to bring up to the state, please let me know, please let Pam know. Happy to do that. The next state meeting is February 6th and 7th in Troy.
All right, thank you, David.
Yes.
Just one additional thing, an interesting, piece when Dave's talking about medical directors, and this discussion is happening at the state level as well to some degree, is compensation for medical directors. Right? There's lots of discussion that medical directors really can't be engaged if they're doing it for free, right? They don't want it to be a signature any longer. They want the medical directors involved, and so it may be necessary, right? And again, this is stuff that's happening, right? And it's important, but it may be, right? An agency may not feel as bad about contacting the medical director if they know they're getting paid, a stipend, right, or whatever it is, but just some kind of engagement from medical director. So just so you know, the conversation is happening, and actually, it may be out in the report that comes out later this quarter, but that's a discussion.
Yeah, it'd be nice, having done this for 30-plus years for free.
Me too.
From multiple agencies.
I've never asked for
Well,
money.
again, I mean, it's turning into a
With back pay, right?
All right. It's turning into a
Maybe we
signature.
can retire then.
Yeah, it's turning into a signature. They don't want that. They want
Yeah.
medical directors engaged. And we know that as the system moves forward, we need to have engagement from medical directors. So from a professional perspective, it's critical.
Interesting. Yes.
The follow-up to that question is, there's a lot of discussion about medical directors and the need for their malpractice to be adjusted for their coverage of EMS.
And so, one of the other things, and I haven't looked at it, there is a national EMS medical directors guide that's available online. But I know, as an example from my previous agency, is that we had specific insurance for our medical director.
Yeah, they should provide you with that.
That we provide.
That they add on to their
that
policy.
stuff is absolutely gonna have to be looked at.
Yeah.
And some of that is covered in that national medical director's guidebook.
And it might be there and they've just not told you, because most of them do it automatically, because it is something you want in place.
So there's a National EMS Medical Directors Association or something.
Yeah, it's actually a whole reference to, guidelines of what they think you should do, the whole process. It's a huge thing. Okay, now new business, open forum. Anything anybody wants to bring up? Yes?
Okay, so I was looking at my email, and, one of the things I get is from EMR ISAC. Have anyone ever heard of EMR ISAC? Emergency Management Response and Information Sharing and Analysis Control. It comes out of the U.S. Fire Administration. So one of the things that is happening, and is actually open for comment now, is that OSHA is expanding protection for emergency workers from just fire to across the board. And they had this document came out, it's 608 pages. I've just barely started to wade into it, but I think it's going to, I think it's going to be a good thing, and it's going to throw some protection to all kinds of emergency response folks. I know I looked at it because it came to me on my Health and Human Services ASPR site, because one of the things is, all of our people who are volunteer or, are part-time federal employees in disaster response, don't really have a lot of protection. They go out and, and the same thing with our volunteers, the same thing with our paramedics. If they get hurt on a job, maybe it's a job that they are only working occasionally. Okay, and they get hurt on that job. then they can no longer work in any, their other maybe full-paying jobs. Okay, the same thing, you go out on a federal disaster response. And it goes across the board. So they have these standards for fire, but now OSHA's actually getting into this and expanding this out. We're now into, and we're now into it, there's actually an open comment period. So what I will do is I can send you this document.
Yeah, send me the link.
And people should take a look at it, because I think
I'll
we
comment.
may want to comment. But it also may give additional protection of, look, OSHA standards have protected workers in many industries from some pretty horrendous things. And so finally, they're taking a look at it here, and so I would highly recommend, like I said, they're in an open comment period now. I'm certainly encouraging the folks in the federal government to take a look at this. And we're gonna be discussing it, but I thought it's definitely an EMS issue, for sure.
Yeah, I would like to see it. Send it to me.
So I'll send it, and we can distribute it out.
Yeah.
But anyway, anyone can get this, these are, EMR Isaac sends out these infograms. So, just in terms of, data overload for all of us, I don't usually, look at all these things. I mean, I might scan them for relevant stuff, as we probably are doing hundreds of these types of scans we all do every day. But anyway, this is out there, and OSHA's seriously looking at this whole field.
Interesting.
Yeah.
That's great.
Okay, any other comments, concerns, issues? Well, I want to thank everybody for being here this morning. I'll take a motion to adjourn. And second, thank you. All right, thanks, everybody.